Good afternoon. My name is Kelly Diak. I'm very excited to be able to present to you. I've spent my entire career in the laboratory, having been in the field for a little over 30 years with my cytotechnology certification, as well as my specialty in cytotechnology, my histology certification, and my MPA. I worked in histology and cytology on the bench for about 10 years, transitioning to an AP leadership role during that time. And then for the last 20 or so years have overseen the Anatomic Pathology Departments as the technical advisor, along with some regulatory and compliance obligations to our laboratory system. So I do have experience with single site departments as well as managing a system AP department with a core lab and satellite locations feeding into that central locations. So in those 30 plus years, I've been involved in a little over 30 inspections, both as an inspector and as one being inspected. And during that time, I've learned many lessons and developed a sense of what is expected during an external assessment and how to prepare. Additionally, I like to share what I see most frequently as an inspector and what I struggle with personally in terms of regulatory compliance. My career goal is to assist others in preparing for a successful inspection and to give ideas on how regulatory compliance can be met. So with that, not going to spend a lot of time on the agenda here for sake of time, but these are the items we're going to go over. So with that, let's start with what I see as the most challenging regulatory expectations. So a little more than your typical top 10, here are 14 areas that either I have struggled with while I was being inspected or have seen others struggle with during inspections. I'm not going to read through all of these now, but I will have 2 slides dedicated to each challenge. So the first slide calling out what I often see being deficient with each one, and then on the second slide, we'll talk about expectations and suggestions for compliance. So training and competency is the first topic that we'll talk about. So common findings involving training and competency include training documents not being available for all staff that are working in the department. This includes training documentation that is used to demonstrate training, but upon close inspection is not sufficient. For example, the training documentation does not include all of the test systems for which a staff member is responsible. Competency is probably more challenging for departments than training, whereas competency documents are often not present, or similar to training, the competencies don't include all of those test systems. Oftentimes it's the frequency of the competency that's found to be insufficient, and by that I mean either the dates of established staff do not follow the expectation of an annual competency, or for new employees, that expected 6-month and then subsequent annual competency is either not performed or again, the dates are not acceptable. Competency is often not reviewed appropriately, meaning it's not signed off by the person in the right CLIA role, or it's not documented as reviewed at all. And often I see competency delinquent in terms of what the competency appears to be assessing. So each test system that is included in a competency must be assessed for the relevancy of each of the CLIA elements. The competency must cover all of the appropriate CLIA elements as applicable to the test systems. If the competency does not cover all appropriate CLIA elements, that competency is considered incomplete. So delegations must be made as to who can perform competency, and this should line up with staff who are assigned the CLIA roles in each lab. General supervisors can perform competency for high complexity testing, provided they meet the educational qualifications. Staff that are assessing competency must be delegated that role. It's quite common to find that staff who are performing competency on moderate or high complexity testing personnel have not been delegated that responsibility and therefore are delinquent not only in the lack of delegation, but also in all of the other expectations of a staff member that have been delegated a CLIA role. So how do we achieve compliance for all of the training and competency expectations? So let's talk about what we expect to see in terms of documentation for training and competency. Documentation for both training and competency should be available for every employee. This is particularly true for staff that are considered high complexity testing personnel, including those non-pathologists that perform gross tissue exams, cytotechnologists, and any staff who evaluate imaging systems. High complexity testing personnel should have training documentation as well as competency that fulfills all 6 elements of competency as defined by CLIA. And then that competency must be performed at 6 months and then a year during that first year of employment and then annually thereafter. While histotechs, prep techs, and assistants are not considered high complexity testing personnel and are not required to abide by the same competency standards as those that are, it is good practice to demonstrate that competency for all lab staff as well as evidence of training. Any staff holding CLIA roles for high complexity must also have documented competency for that CLIA role. This includes your general and your technical supervisors. And then finally, pathologists are required to have a professional competency documented. Now that we've talked about what documentation we should have in order to be compliant with the training and competency standards, let's talk about ways to manage these programs. Documenting on paper how your program works is one of the keys to achieving compliance. So create training documents that'll drive that training process for your trainers. Create a document that outlines those CLIA roles that you've assigned in your department so you know exactly which staff are assigned which roles. Create a document that lists out those test systems and then indicate which of the 6 CLIA elements is appropriate to be utilized within the competency of that test system. And then finally, documents that lay out exactly what you are assessing for each competency and how are helpful to show how you are effectively performing competency on your staff. Electronic systems are always a plus to help manage competency, really for any size lab. Competency can be very tricky to track, I have found in all my years. It is helpful to have a system that can track all dates and help keep you on time with assignments. I've seen some labs do competency on an ongoing basis throughout the year. Personally, I think this is difficult to manage and have found it easier to have a competency season or competency window, if you will, where everyone does competency all at the same time and then it is over for the year, except for your new employees, of course. So educational documentation can be tricky sometimes because of the variation in the presentation of the transcripts, diplomas, and equivalency documents, depending on which institution generates them. Educational documentation is often not available or cannot be found for staff. Documents that are used to demonstrate an employee's education are often without the necessary information to assess the qualification that is needed. And then finally, staff are often assigned roles that they are not qualified to fill based on the documentation of their education that you have on hand. So let's talk about this requirement just a little bit. The documents that demonstrate staff education must have all of the essential elements. It is a requirement to have the field of study listed on the document that is retained for educational documentation compliance. This is the only way to confirm CLIA requirements for education have been met. If the diploma is what has been submitted for educational documentation and it does not have the field of study listed, then you must obtain that transcript. So for example, sometimes the diploma might state just Associate of Science, and that's not good enough. You need the document to tell you what the science was. So again, for that example, the transcript would indicate, Associate of Science, and then should demonstrate a field of study or a major listed as, biology or chemistry. Educational documentation should be retained for all high complexity testing personnel. This would again include any pathology assistants, cytotechnologists, and personnel who evaluate imaging system data. For a cytotech, it is acceptable to only have that ASCP certification to demonstrate educational requirements, and this is the only role in the lab where this is accepted. A certification card is not acceptable for CLIA roles or other roles in the lab. It must be that diploma or transcript or an equivalency document. With the change in the CLIA rule recently, we now have other avenues to explore while assessing the non-traditional diplomas. And by this, I mean you have someone who has a Bachelor of Science in something other than a biological or chemical science or medical laboratory, clinical laboratory science, but they have enough credit hours in a science based on their transcript to qualify as a high complexity testing personnel. I'll refer you to the CLIA rule for these specs as that's beyond the scope of this presentation, but just want to make sure everyone is aware that this option is now available since it's relatively new. Additionally, those staff that hold CLIA roles for high complexity testing must have documents available proving their educational background meets the requirements of said CLIA role. So this includes your pathologists that retain those clinical consultant, technical supervisor, and medical director roles. For staff that are not designated as testing personnel, the only educational documentation necessary is what is dictated by the facility or the job description. So some ideas on how to ensure you have the educational documentation that you need. The availability of these documents is critical during an external assessment. So my preference is to have these on hand in the lab. In some organizations, HR holds these documents, and I have found this to be very chaotic when I have had to go to HR and have all these documents pulled. It just puts stress on the inspectors, as well as HR, as well as myself. And I just think it draws out that inspection because of the time it might take to engage AR. So at our last inspection, I had my inspectors go through every single one of my testing personnel and review their educational documents, which is the very first time I have ever had that done. And for 200 people, this took an incredible amount of time. If I did not have this on hand, in an electronic kind of central location, I'm not sure they would have ever gotten through everybody in a timely manner. And that was just for one of my sites. So speaking of audits, this is my number one suggestion for compliance in this area. The more you audit, the more you are aware of where your gaps are. Auditing is helpful for both educational documents and the assignments of CLIA roles to make sure you are meeting regulatory standards. Additionally, it is easiest to address the majority of these items during the onboarding process. Of course, you also need to have processes in place for when CLIA roles are added to staff during their tenure. Again, an electronic system to house this documentation I have found is the easiest way to both organize this information and control it. Staff often move around or have roles added to them throughout their tenure. When these documents are electronic, it is easy to access them and assess their ability to fulfill the role that is looking to be added. Additionally, it allows for auditing to be performed on a regular basis because they're readily accessible. And then finally, while I know not always possible, it is very helpful to have a single owner of these documents and process so that it can remain in control. So as I alluded to earlier, CLIA roles can be challenging and gaps are often found because the understanding of the CLIA role and who can fill it is lacking. As related to CLIA roles, the regulatory challenges include staff are assigned to roles that they are not qualified to fill, or roles that must be filled have not been assigned to any staff. It's common to find that employees that are assigned to a CLIA role don't have a competency assigned to them that assesses whether they are fulfilling the CLIA role appropriately. Additionally, there is often no written document that outlines which roles have been assigned to staff. This is essentially that delegation from the medical director, so it is a critical piece to have. And then finally, the organizational profile for those that are CAP accredited does not reflect the CLIA roles assigned. So it's critical for all CLIA roles to have a staff assignment because there are responsibilities tied to each role. And if you don't have anyone assigned to the role, then you have no one to complete the responsibilities that are essential and required for a department to operate. For AP, there should be a technical supervisor for histology and cytology and a general supervisor for histology and cytology. This, of course, is in addition to the medical director and the clinical consultant roles. Creating a document that lists all the staff that are assigned these roles is an easy way to keep track of these assignments. Additionally, this document can be signed off on by the medical director then to further document that delegation that they're required to make. Furthermore, this document can then be used to complete the organizational profiles and audit to ensure that they are accurate and up to date. So having a process to regularly assign and remove these roles and review educational documentation held and competencies for the role is the best way to ensure that you have this organized in such a way that promotes compliance. The activity menu is a challenging aspect of every department in the lab. It is one of those things that is out of sight, out of mind. AP is certainly no exception. And it can be very dynamic. It is a very frequent occurrence to find the activity menu that your accrediting body holds out of date with what is actually happening in the department in terms of what kind of testing and activities associated with that testing are taking place. So accrediting bodies, whoever they are, must be updated with our current test menu and testing activities. If you are CAP accredited, this information drives the custom checklist so you can understand why this becomes an issue, and this is why it is actually a standard on the CAP checklist. If the activity menu is incorrect, then when inspectors come in to do your inspection, the checklist does not accurately reflect what it is they are to inspect. So how can we work this into our regular activities to make it more of a habit to review and update? First of all, make sure the right people have access to update the accrediting body. If you have too narrow of a control on this, things get left off. On the flip side, however, I don't allow too many people to have access to this either, because then updates kind of happen and maybe they aren't accurate or shouldn't be happening. So auditing the activity menu that is shared with your accrediting body is critical. It should be performed on a regular basis. Leaders should be asked to review their activity menu on at least an annual basis to ensure its accuracy. For CAP accredited facilities, this should be done thoroughly at the time of reapplication. Adding this activity as part of a larger process when tests are being brought in-house, testing processes are changing in any way, and when testing is being eliminated is helpful for staff to remember that this task must be completed. Additionally, when you can include an auditing activity that requires a review of the activity menu as part of other activities, they tend to be less likely to be overlooked. There are some checks and balances that help with this, but they are not 100% effective. Because of the reporting requirements for CMS regulated analytes, there are flags that get thrown when either you receive PT you no longer need, or you are ordering PT for something that is not on your activity menu. As I stated though, this is not the end all be all to monitoring this. It's just another way for you to identify gaps. So moving on to equipment and instrument maintenance, quality control, and general records associated with equipment and instrumentation. This is another regulatory compliance challenge I often see. There are many pieces of equipment and instruments within any one given lab. The program for the maintenance and quality control of these items must cover every one of them that is used in patient testing, directly and indirectly. So some of the things I've come across with equipment and instruments that are used in the department include no schedule being outlined that lists out exactly what needs to be done to each piece of equipment. Staff are found to not be doing what the policy or procedure dictates. It is common for policies to not be entirely accurate, that being it doesn't follow manufacturer's instructions as to how the equipment or instrument is to be maintained or what QC is supposed to look like. It's also common to find documentation of quality control or maintenance to not be accurate and for required activities to not be documented or the associated documentation cannot be found. Documentation of our maintenance and QC is critical. You've heard that adage, if it's not documented, then it wasn't done. And above all is the frequent occurrence of lack of corrective action when something falls out. Corrective action is often not documented as to what was done to mitigate the situation. And then lastly, these documents are often not reviewed monthly, and they are often not reviewed by the medical director or designee. Those acceptability ranges are often found not to be included on documents that are used to assess the instrument or equipment. So keeping up with all of the expectations of your equipment and instruments takes a lot of time. It is like keeping up with your old car maintenance and repair times like 15 or 20. So let's start with the policies. Your policy for each piece of equipment must match your practice. Do what you say you do in your policy and make sure your policy matches the manufacturer's instructions. All equipment and instruments should be included in your program. Documentation for maintenance and QC must be complete, done at the frequency indicated, and able to be understood, meaning if you have a QC form that is supposed to be completed daily, then I would expect there to be something documented every day that that lab is open. If you use a check mark as an example, then it should be clear as to what that check mark means. Does it mean it was completed or something else? If you use a dash, what does that mean? Does that mean it wasn't done or does it mean something else? Be consistent in how you document. So if a check mark means it was completed, I should see a check mark consistently on the form when tasks are completed as expected. Additionally, any maintenance you have completed on the equipment, whether it's preventative or as a result of an issue, must be filed in an organized fashion so that it is easily retrievable. The last expectation is documentation of that corrective action when things go wrong. It's not good enough to just indicate that a particular piece of equipment is not working as expected. So for example, if you have a fridge that's not holding that acceptable temperature, when this happens and it is indicated on the QC form, you should also be additionally documenting what you did with the contents of that refrigerator. Did you take everything out and move it to another refrigerator? Or did you get a new refrigerator and replace it? You need to indicate that directly on the form so that it's clear what was done during the time that the refrigerator was experiencing those problems. It needs to be clear that you didn't leave the reagents in that refrigerator while it was experiencing the problems. So my mantra continues with auditing. Audit completion of your maintenance and QC programs. Make sure that the forms are completed and appropriate. When there's a fallout, ensure that you have corrective action documented. Legends on forms often assist with making sure that your staff are completing the form consistently and ensuring that everyone knows what a certain notation means. So if one person uses a check mark and someone else uses an X, does this mean something different? An inspector could easily become confused if they see this regularly. Same thing with NA or a dash. What do these mean? The more direction you can give your staff on how to fill out a form, the more meaningful that form will be and the more straightforward it will be to the person assessing its completion. So when you're reviewing that documentation, whether it's the daily, weekly, monthly, make sure you're actually reviewing it. Don't just sign off on the form or document. Acceptable ranges should always be included when you are including a quantitative number as part of your assessment. And then part of that process of bringing in a new piece of equipment or transitioning it out should be the creation or reconciliation of the documents used to monitor its performance. So keep track of when you receive something from the manufacturer and review your policy to ensure there are no updates that need to occur as a result. Every lab should either have a binder that houses all the documentation for a particular piece of equipment, including QC, maintenance, documentation, and general records. This binder could be a physical binder, or you could have an electronic binder on a shared site where all this information is housed. The more organized you are with this, the easier it is to maintain and have available when you need it. So moving on to test validation. Test method validation is a hard process. It takes a lot of time and energy to validate each test you bring in-house. It is a critical part of ensuring that the results we are providing are accurate, however, and it is crucial to patient safety. It is often the case that validations are not completed or available. Validations are often incomplete in terms of the documentation, and then it is frequently found where validations have not been reviewed, signed, and approved by that medical director. So test method validation documentation must be on hand and available should it be requested. So this includes documentation that new predictive and non-predictive antibodies that were implemented have had a validation completed prior to going live. It also includes the lot-to-lot comparisons for IHC antibodies and their detection systems. If you perform ISH, new probes must similarly have validations performed as well as lot-to-lot comparisons. Validation documentation must be present if you made changes in processing protocols, including decalcification changes. And then finally, thin layer cytology methods need validation performed upon implementation. So again, having policies and procedures in place that give staff a reference guide as to how to perform a validation or verification is very helpful. Since validation and verification is not always a process that you do on a regular basis, it's very helpful to have a resource for staff to refer to so that they don't invent their own process. Additionally, I've always found that forms and checklists are very helpful in driving a process and ensuring that steps are not missed. Documents that lead staff through every step of the expected validation or verification process are extremely helpful. So quality monitoring is an essential regulatory compliance activity, but one that is often not done well. Monitors are often not available to cover the span of testing that is performed. Data is often found to be collected but not reviewed or aligned with any action if compliance is below threshold. And then annual review of the quality program is often found to be missing or is not completed within the expected time frame. Quality monitoring is very important for every department and will always be a topic of discussion during inspection. All departments are required to have monitors established, and histology and cytology is no exception. Quality monitors must include those items that are required to be tracked by our regulatory bodies. If a lab is CAP accredited, that includes those things like monitoring associated with turnaround time for frozens and your final diagnosis IOC correlation. In addition to the required monitoring, there should be other monitors in place for things that are high risk, high volume, and problem prone. Monitoring should cover all phases of testing, pre-analytic, analytic, and post-analytic, and then that data should be trended over time and available as well as communicated to the staff. Again, corrective action must be shown when monitors fall below those thresholds. And the bottom line to all of this is, what are you doing in the department to ensure that you are providing good care, and what are you doing to improve the services provided? As I mentioned, the more important step of quality monitoring is ensuring that you are putting corrective action into place when the compliance falls below a threshold. You must do something about data that is gathered and either shows a failure by the employee or by the process. Inspectors will look for this data guaranteed. The corrective action or actions taken is just as, if not more important than collecting the data itself. So, collecting a bunch of data with no outcome has no purpose and is not reflective of an effective quality improvement program. So what has been done to ensure your quality program is effective and compliant? Again, having that policy in place to document your quality program is not only required, but essential to ensuring staff know and understand what the program is, how it is run, and what the expectations are. I would recommend to review all quality monitors at a leadership committee level on a regular basis, discussing things like trends and what is being done to address monitor fluctuations or monitors that fall below the threshold. If you are part of a system laboratory, you can leverage this structure to understand best practices. For example, if one facility is above threshold and another is below, is there something that can be done differently at the facility that is within compliance that you can implement to bring that monitor within compliance? To ensure that the annual review is always completed, I have found it easiest to schedule this activity to occur at the same time every year. Staff involved learn to anticipate it, and it's not forgotten. They often will come to me and ask me, like, is it going to be assigned soon? I do make a form associated with this activity that leads the team through the expectations. And this is an example of what I mean when I use an activity where I include other activities, as I suggested earlier in the presentation. I have leaders review their activity menus and testing personnel and CLIO role rosters as examples at the same time they are completing their annual quality program review. It's been very successful and an effective use of everybody's time. The next topic we're going to discuss is root cause analysis, or RCA. Root cause analysis requirements can often entail lengthy documentation of an event that occurred. It's getting really into the weeds of a situation and really diving into every step of the process. It is often said that mistakes that are made by the staff are not the result of carelessness, although sometimes they are, don't get me wrong, but often the result of a poor process. It is often found that root cause analyses are not performed when they should be. In addition to performing the root cause, corrective action must be listed as steps to be taken in order to prevent the event from occurring again. RCAs are often seen without this corrective action, carefully thought out and listed. And then additionally, not only should corrective action be listed, but it needs to be completed. So that final step of closing the loop, if you will, is often not completed. So parameters must be defined for when an RCA must be performed. Once you've completed that RCA in terms of the steps taken during the event that occurred, thoughtful evaluation must take place as to what the lab can do in order to prevent the situation in the future. This could include many things: policy change of workflow, etc. More often than not, there are multiple corrective action steps documented. The key to an effective root cause is to then ensure that the corrective action was actually implemented, and then to monitor that corrective action to ensure that it was effective. You might need to change directions if you find that your corrective action is not working. You're going to hear me say it over and over again, but that first step in being compliant is having a policy in place that outlines when you do a root cause, how you do a root cause, and what the steps entail from start to finish. Many times there are templates available on the hospital level when labs are part of a larger organization. Otherwise, any kind of root cause analysis template will work. Leadership must be involved in that assessment and evaluation of a root cause. Changes that might be made as a result of a root cause or corrective actions taken generally involve leadership direction, approval, and buy-in in order to implement. So it is critical that they are involved from the start. This is another one of those things that I bring to a quality committee, and I would recommend that something similar to review it and determine those next best steps, and then also to ensure that the loops are closed in terms of action being taken. For labs that use CAP for PT material and are accredited by CAP, there is familiarity with the PT attestation page. This is documentation that the medical director or designee is attesting that PT rules are followed. Oftentimes, these are not signed or they cannot be found. Another common finding is that the physical or electronic signature is not present. Instead, the name is just typed on that attestation sheet. The attestation form is often found to be incomplete. For example, the names of the testing personnel that perform the testing is not present. And then finally, the attestation is signed by someone that is not authorized or qualified to sign the attestation forms. So compliance is achieved here by again, you're going to hear me say auditing processes. That attestation page must have either a physical signature or an electronic signature. It cannot just have the name of the medical director or designee typed on that form. Testing personnel must be listed, and then that page must be evident for each PT event. It must be clear that it was completed every time PT was performed. PT is sometimes hard to keep track of in terms of all the paperwork. So at least annually, PT should be audited. And that would include making sure that all of the PT was completed and accounted for, and then a few other things that we're going to talk about in the next couple of slides. Specific to the attestation page, that audit should include the presence of an accurately completed attestation page. And then again, you have those policies that are in place that sort of delineate out all these processes. Still associated with proficiency testing, the next compliance challenge is the PT result evaluation itself. So that document that's received back after the PT event has been graded or evaluated by the PT provider. Complete review of these is a must. It's important to remember why we do PT. It's to detect errors and failures ahead of time. So oftentimes it's found that the PT evaluations have no evidence of review. Similarly, there is no documentation of corrective action on failures. And then we find assessments of the evaluations and review by the medical director or designee is either not evident or not appropriate. So all results that are listed on the PT evaluation should have some evidence of review. Failures should have further investigative documentation. Generally, this includes another form of sorts to document all the necessary steps of elements of the corrective action taken. So when there is a PT failure, steps must be taken to demonstrate what action was taken to ensure that the PT failure does not impact patient safety. The medical director or designee must sign the evaluation report and the investigation documentation as appropriate. And I found that the best way to ensure my PT is in compliance is twofold. First of all, I make sure that the team is performing timely, effective reviews immediately at the time of the PT event upon return and assessment of those results. This means, don't let those results sit on your desk for 3 months before you take a look at them, and don't just sign off on the documents. Review them in their entirety and make sure that the documentation that is being produced is achieving what PT is set out to achieve. That is, ensuring that your patient testing is accurate. And then secondly, again, auditing. I have found that is very helpful with this particular challenge. Having a third party just review the documentation for completeness, not necessarily clinical validity, can help with missing or inappropriate documentation. And I generally recommend that this be completed at least yearly. So active documentation is always a challenge. And by active, I mean those daily, monthly, ongoing documentation forms that are required to be completed in every department of the lab. For obvious reasons, it requires the action from a staff member. So sometimes a single person, sometimes many, and it's always a challenge to keep on top of this. Issues with forms is quite a common occurrence. Forms are often not completed as intended. The wrong version of a form is often found to be used. The process for completing the form or the way it is completed does not match what the policy says. Correction fluid or tape is often found on forms. And then that correction that needs to be made is often not made using the approved process. Instead, you find the staff member has colored in the cell, for example, in order to ensure that that form looks more clean, if you will, as opposed to just marking through the incorrect piece of information. So forms that are utilized in the lab must be the current version. They should also be completed in the same way across the department. So again, going back to my check mark example, if a check mark is used to indicate a task was completed, then it should be clear that is what it means and is consistently used. Corrections cannot be made with correction tape or fluid. Corrections made on forms must be made in such a way where it is clear what the old data was prior to the correction and what the new data entry now is. It must also be clear who made the correction on the form. If there are other expectations that are outlined in the policy, these must also be followed. So how do you get your staff to fill out those forms in your department correctly? Well, I first start by educating. Staff should regularly be trained on how to fill out the forms and how to make corrections on the forms. Errors we know are inevitably going to occur. Lab staff are always very particular about making sure that documentation is neat and tidy. So when an error is made on a lab document, we like to white it out and place the new entry on top. Unfortunately, this is not acceptable. So those original entries must be visible, correction tape or fluid cannot be used, and the corrected data must be clear along with the identity of the person making the change, even though this makes the form look a little bit messier than we would like. Information should be included on the form to delineate various markings and what they mean. So basically, legends should be included so as to define what you expect on the form and what each notation means. Include laboratory forms in the document control program and train staff to obtain their forms from your document management system, whether that is an electronic system or your source of truth binder, as might be the case with a manual process. This can help with ensuring the current version is being used. I will warn you though, this is often an uphill battle because folks like to keep those file folders with copies of forms for use by the department. That is a constant battle of mine. The next challenge we're going to discuss deals with those offsites that need to be performed by the medical director. I often find that these are not completed or not documented, or they're not completed with the appropriate frequency. With the CLIA rule change this year, there was a modification made to this requirement. Offsite visits are still required biannually, however, there must be at least 4 months in between each site. So facilities located away from the lab that hold a certificate of accreditation are required to have oversight documented when the medical director is not primarily positioned or regularly present at the site. So in AP, this is necessary if you have like off-site frozen section facilities. If staff are not present at these sites, an assessment of staff, if staff are present at these sites, an assessment of staffing adequacy must be performed. If you don't have any staff present there, then the only thing the medical director needs to perform is that physical and environmental conditions assessment, along with an assessment of just general oversight activities as needed. So these things might include like PT, QC, safety, quality monitoring, etc. Documentation must be completed for each visit and include those things that only a medical director can do, as I mentioned, in terms of assessing the physical and environmental conditions, as well as the adequacy of staffing. Medical directors should assess other items as related to quality and safety. They don't have to do all of these things every time, but smattered throughout the year, those are key things that they can take a look at. Medical directors are so very busy and wear so many hats. I do try to do what I can to help them schedule these visits. Over the last few years, I started putting Outlook invites on the calendar once a month with a reminder to do those offsite visits, including the expected frequency for their reference, and this has been very effective in reminding them that it needs to be done. Medical directors are expected to scan these materials to me then after the visit, and then I review and put them on a shared electronic location. I've also created a form that the medical director can use to document their site visit. This form has check boxes for the most common items that they may assess when they're there, so they can check off the box and then add commentary as appropriate. It helps set that expectation, and generally speaking has been very successful. And then again, I've created that central repository to store all of those so the entire leadership team has access to them. So a number of items are included in what I'm calling temperature monitoring challenges, which is why this is probably always something that I see falling out. There are just a lot of expectations when it comes to temperature monitoring. Corrective action isn't always documented. It's not clear what's acceptable. It's not always an appropriate, is not always an appropriate use of that min and max thermometer. Documentation of the actual monitoring is not indicated. Always issues when departments are closed on weekdays or holidays. The documentation of the QC isn't appropriate. And then finally, monitoring of temperatures is not occurring in all areas where temperature needs to be monitored. So temperature monitoring can definitely be challenging and requires attention to detail. Anything that the manufacturer's instructions mandating that a particular reagent and or supply be kept at a certain temperature must have temperature monitored on a regular basis. So this includes both temperature and humidity. In the case where reagents and supplies that require temperature monitoring are stored in areas that are not staffed 7 days a week, it is imperative to have minimum and maximum thermometers so as to ensure that the temperature did not fall out of range when staff were not present. Additionally, there must be documentation of that min-max temperature when the staff return. So when temp is out of range, we must document corrective action. This corrective action must include what was done to accommodate the reagents and supplies when the situation was corrected. So for example, you could list on there contents were moved to another refrigerator. That would meet the expectation. And then again, those policies and procedures need to be in place to document the process and expectations. Ensure that checking those manufacturer's instructions for temperature requirements are baked into the process of receiving materials in the department, particularly those that are new items where you might not be familiar with the expectation and it might be different from anything you currently have in the department. Include a physical inspection of temperature monitoring in your ongoing auditing processes. Some places include this with a safety walkthrough review. Basically, try to include it with something else you already do so that you can kill a bunch of birds with one stone. Policies and procedures is probably one of the biggest and most ongoing challenges for laboratories. And that's just because maintaining policies and procedures in the entire document control program is just a massive undertaking and requires input from every member of the leadership team. I think that compliance has improved as labs transition to electronic systems, at least in terms of document control. But I think the challenges have now just transitioned to something different. Oftentimes I find incomplete procedure manuals. Additionally, and probably one of the biggest and most consistent challenges I see in the histology and cytology areas, and really in the lab in general, is that concept of saying what you do and doing what you say. And then just as important, making sure that all staff know what your policies and procedures say and are aware of how things are supposed to be done. If you say in your policy that you take a particular monitor and post it in the department and discuss it at your monthly meeting, then as an inspector, I should be able to go into that department and find that monitor posted and be able to review meeting minutes that show departmental meeting discussion. This is a simple example, but you get my point. Many labs get tripped up because they have this beautiful policy in place, but then staff are not following it. Furthermore, for labs that have electronic systems, backups are often not found. These are used as reference should the electronic system go down. And then in terms of document control, that revision history is often not clear. Although again, with an electronic system, this is much more tightly controlled. As well as document control in general, what is the current version? It is harder to be non-compliant when you have an electronic system. Same thing with medical director sign-off. I see this as a deficiency in labs that do not have an electronic system because they are still passing paper. The final challenge I will discuss is a sign-off by the medical director in the appropriate time frame when there is a change in directorship. This is a very big task and a common finding when this has occurred at the lab. A document control system must be used in every laboratory. It can be electronic or manual. It doesn't really matter which one you have so long as you have one. Electronic is generally much easier because you remove that manual factor that makes document control so difficult. Document control is exactly as it sounds. It is how you ensure that you have the most current version available, a tracking system for historical changes, and a means to organize your policies and procedures so that staff can effectively use them as a reference. All processes in the lab must have a policy or procedure written for it. One of the key elements of policies and procedures is ensuring that, number one, your staff know what the policy or procedure states, and number two, that this is the process they are actually following. Anytime there is a change in medical directorship, that new medical director must sign off on all policies within a certain period of time. This is a huge undertaking and one I see labs often falling short on. Either the task hasn't been done at all, or was only partially completed, or the task was just not completed within the appropriate time frame. And finally, it is important that new and edited procedures follow a document control process in terms of review and sign off. Those approval processes must include the medical directors and anyone else you have determined need to sign off on policies and procedures. So how do we manage all these policies and procedures effectively? You must have a system in place to track revisions, what that revision is and when it was made. Again, it doesn't matter whether this is an electronic system or a manual system. It must be clear what version of the policy is current, and access to historical changes must be available. Educate your staff on the location of your policies and procedures and how to find a specific one. Create an educational tool that is assigned to all new staff when they start, and then your staff on this periodically during competency time and randomly throughout the year. Develop a system to communicate any changes to your policies and procedures as they occur. Again, with an electronic system, I have found this to be much easier. Basically, we have our system set up so that any new or changed policy or procedure is assigned to the appropriate staff for review. And then this also helps with training, since policies and procedures associated with new testing must be created and approved prior to implementation. Assignment to the staff involved in the testing ensures that staff have reviewed the policy prior to go live. The leadership team should be reviewing or auditing policies and procedures to make sure they have the right signatures and are being reviewed with the appropriate cadence. Use the time that you are spending doing competency to check your policies and procedures and confirm that your practice matches. I have also found it useful when I write policies and procedures to share a draft with a handful of staff and ask them to review it and perform the process as it is written. This is really to see if my draft makes sense and is able to be followed. In terms of backups, if you have an electronic system, put a schedule in place to perform a backup of your system. Obviously, this is not needed if you have a manual document control system. I generally will put reminders on my Outlook calendar so that I can keep on schedule with getting these done. So lab safety will be the last topic we will discuss today. I always find this challenging to ensure staff are compliant. We often see staff with either no PPE being worn or PPE not being worn correctly. General safety practices are often seen not being followed, including storage requirements. So there are many lab safety expectations to keep our employees safe. While I'm only discussing the most common challenges I see, these could widely vary between labs. There may be other safety expectations that labs find more commonly than I do. The general bucket of lab safety is often a moving target in terms of compliance, simply because of your staffing changes. I think that compliance ebbs and flows. Lab safety is something that we constantly need to be on top of because it is a dynamic hardwiring process as staff come and go. PPE, including lab coats, gloves, and safety glasses, must be worn when working in the laboratory areas, and then they should be worn appropriately. Hoods and splash guards must be available. Drinks and food should never be used in the laboratory. And then you should have appropriate storage of things like acids and bases. Consistent, repetitive education of staff is very important. Educating staff on lab safety at the time of hire and then as issues are identified is also very important. Safety committees that focus on lab safety are helpful because you have lab staff giving input both on the issues that they see as well as ways to correct the behavior or situation. Regular safety audits assist in identifying where work needs to be done or where education needs to occur. Again, including these safety items and audits that are already being performed is an efficient way to do this. Secret shoppers are a great way to audit the safety of your lab. Secret shoppers are often people from other departments that are aware of the safety standards that are expected to be followed or have been coached on things to look out for. These people then, since they're unknown to lab staff, can help catch issues because we all know that staff generally are on their best behavior when they know they are being assessed by either a member of the safety committee or the leadership team. So we've talked a lot about regulatory challenges and what we can do to be compliant. So let's switch our focus here in the last little bit that we have to talk more broadly about external assessments and how we can prepare for them. So I found over the years that it is most effective to take an ongoing readiness approach to the external assessment component of the quality improvement program. And by that, I mean that labs should not approach inspection as a one-time annual activity. This makes for an extremely stressful time for either the interim inspection while completing the required documentation or as the on-site inspection window draws near. Instead, I would suggest an ongoing approach to inspections, which is really the spirit of the intent of external assessments. As leaders, it is our responsibility to make sure that our labs are always compliant with the regulatory standards, not just once a year during the inspection window or at the time of the interim. From a practical standpoint, it also makes a lot of sense. Accredited labs have a lot of expectations set before them, so spreading that work out to accomplish this is better managed over time. If you're CAP accredited, you're probably aware that every year around the summer months, CAP publishes their newest versions of the checklist. They are available on the website. Additionally, they publish some nice documents that assist with the ongoing assessment of the checklist version. There is a changes only document that calls out all the standards that were added, deleted, and revised. There are also custom documents and master documents that can be of use. Annual activities should include a formal audit of the new versions of the checklist as they are published. At our facilities, each leader has an audit assigned to them, which includes a review of any checklist as it applies to their department or departments. They're required to review that newest version and make any necessary changes in the departments. Annual audit activities should not only include reacting to the changes made in the requirements, but it's also a good time to review that entire checklist and your departmental compliance. Again, depending on the timing of your interim, this can be done at the same time. What you're trying to avoid with the principle of ongoing checklist audits is a massive assessment only at the time of inspection, which would have to include all the checklists that have been published since the last inspection you had. This is just not a good practice because it means you were non-compliant when the newer edited standards were published and really doesn't give you the opportunity to appropriately change or implement new processes. So as checklist audits are performed, it's a good time to review all policies, procedures, and forms, making any revisions and creating new as needed. Additionally, implementing new or revised work processes is easier and more effective because you have the time before inspection to not only create or edit the accompanying policy or procedure, but you also have time to educate your staff, which is a required part of either implementing new processes or changing those processes. So one of the biggest pitfalls of waiting until right before inspection to verify compliance is that if there are changes that need to be made, there is often not enough time to fully execute that changed or new process. Just writing up a policy to reiterate the standard does not fully meet the expectation. So as I get my teams ready for inspection, there are a few activities that I'll perform independently, and then a few I will perform alongside my leadership team. The first activity is a document control audit. I'll do a walkthrough of the department, and honestly, I do this on a regular basis and look for things like policies posted on bulletin boards or walls, post-it notes, cheat sheets, etc., that are being utilized throughout the department. Generally speaking, when I find documents of this type, in particular to the posted policies and any cheat sheets, I'll ask the leadership team to remove and discard. And the reason I do this is that these sorts of employee-created tools often lead staff to do things that are not in line with that documented policy or appear as if they do. As I perform a cursory review of forms the department is utilizing, I will do a check of the document control to ensure that they are using the correct version. Our document control system is electronic, so I'm frequently encouraging the teams to eliminate files where they like to keep copies of those forms, and I ask that they print the needed form from our document management system instead. As I mentioned numerous times, deficiencies are easily cited when documents, including all policies, procedures, and forms, are not well controlled. A month or two before our inspection window opens, our leadership team will complete a review of all evidence of compliance to ensure we have accounted for everything. Again, this doesn't eliminate the possibility that the inspection team might ask for additional examples or have items of their own that they would like pulled. They have the right to do that, but it's very helpful in eliminating anxiety and knowing what you need for the inspection. At the very least, it is a resource to remind you what it is you might be looking for in the event the inspector asks for a different kind of the same example. While mock inspections definitely require a time commitment, they are so very beneficial. It is most helpful if the mock inspection is performed by someone who is familiar with the checklist for the department, but does not necessarily work in the department being inspected. And this is really to just eliminate that bias. This activity can be as in-depth as you want it to be. It doesn't have to be the entire checklist. It could just be a random sample. And they're really just as effective performed unannounced as they are announced. It really doesn't matter. So when I perform a mock inspection, I'll generally take both the histo and cyto checklist with me and then just kind of pretend to be an inspector. I go through drawers, I go through cabinets, refrigerators, freezers, etc. I try to interview as much staff as I can, and this really serves a dual purpose in playing a role to assess department readiness, but it's also helpful for that newer staff member that might not be as familiar with the inspection process. And it really does help them feel a little bit more comfortable. So then upon completion of that mock inspection, I will prepare a report for the supervisor outlining what I would have cited as a deficiency. So in addition to mock inspections to help your team feel comfortable with the process, general coaching is also beneficial. We're getting away from the inspection teams that used to come in and talk to the leader only. Now inspection teams are coming in and are interviewing the bench staff. They know the leaders know what is supposed to be happening, and so they want to know if the staff know. So share those checklists and evidence of compliance with all staff. Make sure they spend time reviewing prior to inspection. Ask your staff to talk through their daily tasks. Inquire if they know how to find things like safety data sheets, or do they know what the evacuation plan is? Can they pull up a policy or procedure? Ask a specific question within a policy and procedure to see if they know what the policy and procedure actually says. Ask about quality monitors. Do they know what their quality monitor is, and do they know what the department compliance is? Coaching my team really does help them understand what is going to happen during an inspection, and then it also gives them ideas of areas they might need to refresh themselves on. So I firmly believe being organized for an inspection is half the battle at making sure it goes smoothly. The more awareness there is of the expectations and the more prepared you are for the inspection, the smoother it will go. This does not, of course, offset the importance of compliance, but it leads to a more effective peer review. So preparing case material ahead of time has always been a constructive method of organizing myself for an upcoming inspection. An inspection team might also ask for their own list of cases and slides. However, I have found it to be beneficial to have things pulled ahead of time. Generally, we'll pull slides, put them in a folder, and then generate the report and place that with the case. We pull a wide variety of cases. And then again, while inspection teams might have their own list of examples they would like to see, having those evidence of compliance ready at the time of your inspection lends to a smoother and more effective inspection. This eliminates that need to rush around trying to find an example of something when there is such a limited amount of time and so many things to do during an inspection. Knowing what evidence of compliance is needed is important, as some activities do not happen every day. So maintaining that list of what evidence of compliance is needed and then sharing with the leadership team so that they know what they need to look for is good practice. Examples should cover the time from your last inspection to the current inspection. Inspectors want to see that you are meeting the standards all the time, not just the month prior to the inspection window. And then examples should also not represent time prior to your last on-site inspection because these are just too old. So a great first impression is to make sure your department is clean. My stance on this is well-organized and clean departments go a long way to demonstrate your attention to detail and importance of making sure you're representing a well-run department. Ensure those floors are clean of paraffin, that supplies are put away, declutter your counters, make sure your instrumentation and equipment is clean, empty garbage, replace sharps containers, all of those things. Make sure you're following your retention policy, declutter your department in that way. And then a few administrative tasks that I would recommend would include making sure that, memos go out to key players within your organization a month or so ahead of time, letting people know that the window is opening. Also putting together a call tree of sorts so that when inspectors arrive, they have an easy way to ensure that everyone is contacted. I've also found that putting a document together that lists out contact information for my leadership team is also very effective for the inspection team to use while they're performing the actual inspection. I generally put together kind of a folder of information that I distribute when the inspection team arrives, just to help with their organization as well. So with that, I'd like to conclude by saying that in all the years I have been involved in the inspection process and working with my departments in preparing for those external assessments, I feel like I have learned a lot. I find great value in being assessed by someone outside of my organization. In my opinion, I do feel like the more prepared I am for the inspection of the department, the less time I need to spend running around for the inspectors, and the more time I can spend appreciating the peer review of the way my department and I do things. I hope you have found this presentation worthwhile and valuable. If you have any questions, please feel free to contact me at my email address indicated on this last slide.